All right, what's up? Good morning, everybody. Happy Thursday. Thanks for joining us, those who are jumping on. Hope everybody's doing well. As for me, I'm heading to Las Vegas tomorrow. We've got the sampler this weekend, so I'm pumped. Got a lot of fun things coming up here over the next few weeks. But this morning, what I want to chat about is some patient questions. So we often get this, and it's huge because really the important aspect of getting folks better is not you understanding what's going on. It's the patient. Hey, what's up, Tyler? It's the patient understanding, right? If you can't transfer your understanding into what's going on with the patient, no one's ever going to move forward. Good morning, Andrew. And I think we oftentimes get so caught up in delving into the depths of our nuances, and no doubt that's important, but the reason it's important, the end game here, is to boil down your understanding into one the patient can really resonate with, and one that can guide the patient through the process. So we've got to tackle both sides of it, right? We've got to take on that responsibility of actually figuring out what we do believe is happening, and then find a way to communicate that well to the patient that really accelerates their process. So one of the most popular questions that we get is, why does cracking my back help? Or why does cracking my neck help? Right? Patients want to understand, what is it about having my neck crack that helps? Right? Now, the way that we answer this and have a fairly high success rate in having this conversation with is, cracking your neck or cracking your back results in a temporary reduction in pain, right? And a nice reflex and muscle activity. Right? Now, what that allows us to do is, when it turns on some of those key muscles, it allows us to strengthen you, to load up those muscles, and ultimately it's getting stronger that rings that victory bell. Right? And so by doing the manipulation, we get a nice relief in pain. That relief in pain oftentimes increases localized muscular activity, right? And that muscular activity results in our ability to load you up and get you stronger. Getting you stronger gets you better, right? So that type of an answer can really help that patient to maintain the locus of control, right? Our concern is always that when we answer that question, the way we answer it, it winds up sounding as though we're fixing the patient, right? And nothing could be further from the truth, right? What we are doing is probably creating an environment within which we can use our ability and our skills to program that patient to get them stronger, to get them better, right? But it certainly is them becoming a physically stronger individual, mentally stronger individual. Those are the things that are really going to fix them long term. So that question gives us a tremendous opportunity to create that paradigm shift in the patient, right? They might be thinking, I'm looking to you to fix me, right? And we essentially turn that around on them, right? And we say, I'm going to do something to help you fix you. So our ability to say, when we crack your neck or we crack your back, right, we're very likely to get significant pain relief. That pain relief will come along with increased muscular activation, right, and some of the deep muscles that are really important to you rehabbing well. Then we're going to be able to place a nice progressive load on those muscles. They are going to respond and get stronger. As you get stronger, you are going to get better. Right? Not only get better, you're going to stay better. By being stronger, you're going to be more resilient, more robust. You are going to go in the right direction long term. So that is our sort of packaged response, right? And it's an honest response. I mean, we're not going to get into all the mechanisms about, hey, we think part of this is a localized reflex, right? There's some great EMG studies showing changes in musculature, but we also think there's a cortical top-down component, right? We also think an expectation component plays in. We're not going to break down what we believe all of the mechanisms are that people respond to manual therapy or spinal manipulation. What we're going to do is we're going to give them an explanation that is true, it's honest, right? But it's also very locus of control aware, right? And it's telling the patient, we're going to use this trick to get you in a spot where you can create a better you, and I'm going to guide you along that process. So those are the kind of language nuances that respect that locus of control and respect that patient empowerment, and those are really, really important things to handle properly. Now, many of you are thinking, Jeff, most of my patients follow up with a question, or maybe they even begin with the question of, does spinal manipulation change the position of bones, right? So are you putting bones back in place, right? Now, when you get those kind of questions, first of all, don't let that get on your heels, right? A lot of folks are like, oh God, those are muddy waters, right? Don't let those questions push you back onto your heels. Instead, think about, how much can I get out of this answer? Right? Because the person is clearly in a position of trust. They're asking you, why does it work? They want your advice. that is a huge opportunity. And you want to not only not cower from it, but you want to advance forward in your response to those kind of questions. So when somebody says, does spinal manipulation change the position of bones? Your evidence-based answer can be, all the research I have seen would suggest that no, it's not the case. But then you want to add something along these lines. And that makes sense to me, right? Because what we see time and time again is that position and structure don't seem to correlate well to symptoms. Whether you're talking about MRI or posture, it's just not something we see in the literature. Right? Now you took the answer and you gave them a good, honest, evidence-based answer. No, we don't think what's going on here is that spinal manipulation is relocating bones or changing the position of bones in the long term. And that makes sense because what we see time and time again is things like structure on MRI, right? Things like arthritis and imaging on MRI, right? Things like structure with posture, right? Those types of positional things don't seem to correlate well to symptoms, which oftentimes brings up more questions on the patient's behalf of, well, what do you mean that MRIs don't correlate well to symptoms? And I mean, come on. Now we've got it teed up, right? It's a beautiful thing. And that is always your goal, is to create curiosity in your patient about salient information, right? If you really think about what you're doing, right, with your motivational interviewing, with your general interaction with your patient, you're trying to create curiosity in your patient about things that, if they were better informed, would affect their overall progression in a really, really adaptive way. Like that's your goal, because once your patient is legitimately curious, once they're asking you questions, well, Jeff, what do you mean the MRI doesn't correlate well to symptoms? Or what do you mean posture doesn't always correlate well to symptoms? What do you mean by that? I thought there was a right way to sit. I thought that abnormal findings were abnormal for a reason. Like, when they start asking you about these things, now you're having really, really important conversations, and they're the ones coming to you for the information. But the way you get to that point is you place little seeds of honest information at the right time in the right manner that causes them to think about these things and causes them to reevaluate maybe their previous conceptions. And that's what gives you that window to have those conversations, right? And guys, the only reason this works, and we've talked about this before, but the only reason that this works is being able to answer in this way where a reflexive mechanism, right, gives us some muscle activation that we can then progressively load, or no, the bones don't change position. The reason people can and will buy this is because they generally aren't as obsessed with pathoanatomy as we think they are. And that is not me saying it doesn't seem that way. It definitely seems that way, right? Your patients come in and they truly do see, or currently are, very, very focused on their MRI results, right? But this is why building the bike is so important. Right? This is why making within session change is so important, right? So when you think about the patient who comes in and they have that MRI that shows some quote unquote abnormalities, and by the way, radiologists are getting much better at saying, hey, these are found in a lot of asymptomatic people. So hopefully in the next few years, we're going to see a few less thought viruses. I know it's a slog. I'm with you, but things are going in the right direction. And as I'm traveling around a lot, I'm seeing that in multiple states. So we are seeing some progress, I think, in the way that radiologists and physicians are reporting findings to patients. So I'm encouraged by that. But no doubt, you've got a lot of patients who are coming in and saying, Jeff, look, the reason I'm in pain is my L4, L5 disc, and it's this bulge right here. Do you see it? The doctor said it was pretty severe, right? A lot of people are coming in with very focused on that conception, right? Now, it's key that, number one, we don't just shove back and pull the rug out from underneath them and say, oh, come on, Mary, haven't you been reading the recent literature in Spine Journal, right? There's very, very poor correlation. Like that's not the approach we take. We do cast little seeds of doubt, like I mentioned earlier, and give Mary a chance to question about whether or not that MRI really holds the key to how she should feel on a day-to-day basis. But what we really do is we make temporary change. Right? So what we really do is we build that bike. So we do a really good assessment of that patient, right? We do a couple of things that reproduce that patient's symptoms in a functional way that are meaningful to him or her, right? Then we do some targeted intervention, and then we reassess those same functional maneuvers. And when the patient says, boy, Jeff, I was unable to put my shoes on at all this morning. I was unable to put my shoes on at all 2 minutes ago when you had a look at it. But now that you've messed around with my back, now that you had me do all of those extensions on my belly, right? Now that you were pushing on my back for a second, boy, it's a whole heck of a lot easier to get my shoes on, right? Now, a lot of folks will say that short-term change doesn't matter. And I'll jump on that bandwagon all day, right? I am not blown away by somebody feeling better temporarily following a manual therapy intervention. What I will say is the patient has a very, very important shift in their cognition at that moment where they say, boy, what you just did to me here in the treatment room created significant increase in my ability to do the thing that I'm having a hard time doing. Maybe we don't need to have surgery to solve the problem if what you can do in this short period of time can make that dramatic of a change. All right. If you don't think that's important, if you don't think that moment of that patient saying, well, I thought it was my disc, but you didn't go inside my spine and do anything, yet I am clearly feeling dramatically better. Maybe there's things we can do together that don't require invasive intervention that might get the job done. Folks, say what you will about short-term changes. That moment of that patient now believing, hey, maybe this can be done without surgery. Maybe this can be done conservatively. Maybe these folks here have some things that are really valuable that can allow me to get over this hump. That moment of short-term change, of symptom modulation, is incredible for the patient's cognition. You know, Justin talked on Tuesday about how important short-term change is to get you to a point of trust where you and the patient, your relationship, can get to a spot where you can tackle some really deep-seated behavioral and psychological concerns, right? I'm talking about the patient having a shift in opening up their mind that conservative care could work, that what you could do might get the job done, right? I'm talking about changing expectation through short-term symptom modulation and leveraging that to get them on board to create a long-term plan of care that solves the problem, right? And the only reason it works is patients are really, really concerned about getting better, right? The only reason they appear to be concerned about their L4, L5 imaging results is because they believe that holds the key to them getting better. Your job is to show them that probably does not have to be directly addressed for them to get better. You do that by really good assessment and reassessment. You leverage those findings to tell them, hey, it's great you're feeling better here short term. The way we're going to make this long term is getting you stronger mentally and physically, right? We're going to help you sleep better. We're going to help you recover better. We're going to help you fuel better. We are going to progressively load you. We are going to turn you into a rock star human, Joanne. That's where we're going in the next 6 to 8 weeks, right? I'm glad we've been able to give you some short-term relief, right? We are going to, inside of that window, we are going to load you up and we're going to make this a long-term better person kind of place. All right? That's how we get the job done. So the reason it works is folks just want to feel better. And once they realize there legitimately is a possibility they're going to feel better with what you have to offer, their overall buy-in, attentiveness, execution, compliance, all of those things elevate. But you've got to leverage all of it, right? You've got to leverage short-term changes and you've got to frame that in a way that doesn't make the person feel more dependent on you, but makes them feel more empowered about themselves. That's where the magic is. Yes, it can be a very slippery slope doing spinal manipulation on somebody as far as them becoming dependent. But if you understand what's going on, and if you honestly believe in the things that create long-term change, and you're willing to voice that to the patient because you're not interested in sounding like the hero, right? If you understand and can do all of those things, you can responsibly leverage short-term changes to get buy-in on patients who were first hopeless, who now have some belief that they can get better if they do the work. You can create that mental shift. It's an art, but it's an art that we have the professional responsibility to try to rise up to. All right. Awesome. So I'm going to do some patient series PT on ICEs because these are fun for me because my biggest challenge is when I'm over in these companies or I'm in clinic. I had a patient on today's Thursday. I had a patient on Tuesday who very much was down this road, and it was really fun to try and work this process. And actually, we had a few emails. I think we're moving forward. It's not a 180 turnaround, but we're chipping away. It's fun to do this because this is the real stuff. Like, again, if all you know is books and you can't get people to believe, right, you're really not going to be able to be of great service. These are the nuances, these conversations, leveraging these questions. And so I'm going to do a few of these, and I hope you guys enjoy that. So, all right, those of you going to the sampler, I'll see you on Saturday, maybe even on Friday night, but I'll see you on Saturday. I can't wait, and I've got a bunch of stuff coming up over the next few weeks, but I'm already probably running over my limit, so get out of here, enjoy your Thursday, get to clinic, make it happen, change some beliefs, and I'll see you guys soon.